unfortunately, due to the war time in my country, we'll have to resort to the full-fledged video lessons, but no live meetings online, unfortunately, since it is very important for me to remain mobile in case we have aerial attacks and stuff. Luckily, in the area where I am right now, there is a lot of aerial emergencies, but I haven't heard airplane just yet, unlike on my previous place where I was staying at. And I guess many of my groups probably have missed some of the lessons starting from the course, so I'll record most of them for you. During these videos, I'll discuss the topic for you so that it will be additional information to the presentations which I send you. With the presentations, I will also send you the tasks to do as your homework, and I will always write the date on which I will check if the homework is okay. Okay, so if any one of you wants to work off a lesson you have missed previously, during the war or before the war, you can do so by a variety of means. So, for example, I may suggest you to do an additional home task, for example, which will be bigger than usual questions, for example, maybe some case studies or something like this, or like situational questions. Or maybe if you want, you may try to do online communication through Google Meet, but I cannot really help if the connection won't be reliable, not to mention the difference in time periods here. Okay, also during the course of psychiatry, we also have a special lesson when we do the interview for the patients, with the patients. During the usual lessons, since there was this nasty quarantine, which messed a lot with my plans and with plans of everyone, unfortunately we didn't meet any real patients, but I usually provided either the videos of patients done in archives of the USSR usually, or I would, which I would prefer, or I would have role-played the patients because fortunately or not, I can vividly show a variety of disorders, not all of course, and I will be talking about the gift to be, or maybe a curse to be with a certain illness later on today. Yeah, but I've tried to provide as much experience as possible to the students, because the main focus of any patient interview for you is to get a grasp of this practice to interview the patient, to be able to choose the right questions and to get information. And for our patients, since they are psychiatric patients, it is even more important, because unfortunately the talk with our patients may be very peculiar, very unusual to the students who are only used to somatic patients. And you know, like from your own personal experiences, all people are different. And when we are talking about the psychiatric patients, their individual differences shine even brighter than individual population, which should be taken into account. Okay. So let's proceed. So today we have the first lesson in the course of psychiatry and narcology. I am Smirnova Lilia Ivanivna. I am a psychiatrist and also the teacher of psychiatry, narcology, medical psychology and psychoanalysis at Psychosis National Medical University, just so you know. Okay, so our first lesson is usually an overview of the course. We discuss the subject and the tasks of our psychiatry and narcology, also development of it, and classification of mental disorders. Usually I try to focus on the most important points because the whole information you can get from the lectures, and I'm sure the lectures also provide you with the plenty of materials, not to mention Moodle and other resources. So I'll try to give you explanations which are much more difficult to get just from plain reading of a presentation or something like that. And of course, if you have any additional questions to me, or maybe notes or commentaries, I encourage my students to email me, or in case if I have provided my contact telephone number with the letter, you can message me in Viber or in Telegram. That depends on what you use. Some groups may not have the full information just yet, because I was snowed under 9 groups very suddenly, and I had to quickly regroup my working process from the offline to the online, and to the online in the wartime. So those are 3 different types of work. Okay, let's start. So what is psychiatry overall? It is a medical science which deals with the study of diagnosis, etiology, and pathogenesis of mental diseases, their rate, and as well as the organization of the aid we provide for the mental patients. What I need you to understand right off the bat, there is a variety of questions you may take into account when you are trying to evaluate a psychiatric patient. And sometimes you may think about those kinds of questions, like what is good, what is bad, what is normal and what is pathological, what is an illness and what is health. I need you to understand, as a future doctor, regardless of your specialization, and maybe some of you will be psychiatrists, I need you to understand that as a psychiatrist, we only deal with the question of whether something is an illness or whether something is healthy. And occasionally, if we need to work with statistics, with epidemiology, we may take into account the questions about what is normal and what is pathology. What I mean by that? Being good or being bad depends a lot on the ethics and the age where you are right now. So that is not the question a psychiatrist should ask about their patients. We are not judging them. That's not our jurisdiction. So that's not our question. When we are talking about what is normal and what's pathological, mostly we are talking about whether something is frequent enough in the population in order for us to think that this is the average one, this is the norm, or if it is rare. Because when the doctors are evaluating illnesses, usually this is done by the second example. For example, we have a certain number of people coming to us with a broken leg. And the vast majority of these people, and we have a lot of such patients, yes, with broken legs, majority of these people experience decrease in their life quality due to this broken leg. A minority of them maybe would benefit from this and would feel much better with a broken leg. So they are not considered ill, but for the majority, this produces more problems. So the doctors gather around and they say, okay, then maybe broken leg is an illness. Maybe it is not the norm, because it declines our life quality and it occurs much frequently. Okay, I may have confused two fields together. What I'm trying to say, sometimes something which is unhealthy may be quite normal and very frequent in the population. For example, people may consume fast food. It is not healthy, but it is not considered pathological. It is just a habit of consuming food. So, or for example, something very healthy may be rare and therefore pathological in this population. For example, some people have very good memory, so that they can remember each tiny bit of any day from their life. You can name dates and they will tell you the whole plan of the activities on that day, regardless of how much time passes. This is a very rare skill, and that's why it is not considered to be normal to be like this. But it is not a bad thing. It is not an illness for these people. They may benefit from this, but it is not frequent. So when we are talking about something which is frequent, we are talking about the norm. When we are talking about something which is pathological, we are talking about something which deviates from the norm. Now, about illnesses and health. In Russian, there is a word which we use to call illnesses, and it is pronounced as болезнь. So, the core part of this word means pain, боль, pain. So, what I'm trying to tell you by this, when the person is having an illness, usually they feel ill. Usually they should feel at least some discomfort from this condition. Without this suffering, many people do not refer to the doctor first in the first hand. And of course, with our patients who are psychiatric patients, a lot of them may not have the full insight into their illness. They may not understand that this illness makes them suffer. But for example, our patients may tell you that, okay, that I do not have an illness, but there is a government who is spying on me, and they are trying to kill me, and they are threatening me. And this what makes me painful. So the person who suffers from this delusion, they may not think that the delusion itself is an illness, but they will feel the consequences of this condition. They will feel the pain from this condition. And of course, they will actively try to do something to diminish this pain. They may try to move to another city, for example, to avoid being threatened and persecuted by the government. So here is this, I think, also. Or for example, when you see a person who claims that they have a psychiatric illness, or like they have a certain illness, but they do not experience any discomfort from it, like at all. For example, I have seen a lot of people claiming to me that they have depression, but apart from their words, I didn't see any signs of depression, and this so-called condition didn't even impact their everyday life at all. I would even hardly consider them sad or something like this. So obviously, these people weren't suffering from their conditions, and most likely they didn't have any conditions. So that's what you should understand. Illnesses usually cause a diminishment in the level of functionality of the person. And this may range from different manifestations. It may be some lighter symptoms, for example, okay, I missed the meal today, okay, I cannot fall asleep because I'm just stressed, okay, I forgot to wash my hair today. This happens sometimes. So those are minuscule symptoms, but they're still symptoms. There's some symptoms of problems in the person's life. Or the symptoms may be very severe. For example, the person is hallucinating. They're experiencing intense emotions, fear, anger, fury, which they cannot control. And what is important, when the person is ill, they do not choose the time and place for their symptoms. Even those people who have histrionic traits and who are frequently blamed for doing something intentionally, yes, their symptoms usually have some secondary benefit, which is very obvious, but they still do not choose when these symptoms happen, when we are talking about legit histrionic disorders. And I stress it, about disorders. So here is that. So the person who is ill and also psychiatrically ill, they usually suffer from their condition. They do not have control over this condition. They cannot choose when it happens, how it happens, and stuff. And also, what else? Well, those are the main things. If I remember something, I will just go along with it, and I'll tell it as we are going along the lesson. So here is that. Yeah, and that is why I was talking about this, is that you may see a lot of people who try to simulate disorders. for different reasons. Oh, yeah, I remember. I remember this thing. Each symptom usually has, I would say, a malfunction inside when it is not adaptive for the person. And also it has a certain beneficial side. So, for example, many of psychiatric patients, they behave very infantile-like. They are like children. Many patients, for example, are not able to perform their usual duties or like to restrain themselves due to their illnesses. And this is a very great benefit. For example, if I don't want to go to the job, I cannot just stay at home and say that, okay, I don't want to do my job today, so I won't do it. No, I have to do it. I bear responsibility. The person who is ill has a documented reason for not to perform their duties. And this is not a bad thing per se. I'm not saying that, oh, you are using your illness as just an excuse. No, I'm not trying to blame anyone on this. But we need to acknowledge the fact that our illnesses usually bear a certain benefit for us, a certain good function. Initial impulse is good for our body because, well, overall, how the psychiatric illnesses mostly happen. The person stumbles upon stress, has a certain, I would say, talent to a certain illness, a genetic predisposition, a certain upbringing, certain environment. So you cannot just get any illness you want from the psychiatry field. No, you get certain illnesses you are predisposed to. So you have this predisposition. You are placed into an environment when you have an unbearable stress, which targets this predisposition. And at first, you fall into stress and then into distress when you are trying to overcome these obstacles. If this stress persists, you may start to maladapt, and at a certain point you develop a neurosis, which is functional change of our nervous system. And I'll be talking about it later as well. So functional change. If this functional change doesn't help you to overcome this obstacle, and obstacle still persists, you have a very high chance to develop a psychosis as well. So here we are talking about reactive psychosis, but I would tell you that actually, well, in my opinion, even endogenous psychosis, even though we consider them to be governed by our organism first and foremost, they also should have at least one trigger from the outside, because nothing in our body happens by itself. There is always a reason for something. Yeah, so a psychosis is an extreme form for the person to stay alive in their situation, to at least exist somehow. For some people, to run away to the hallucinatory world is the only way to survive. And so that's why I'm talking about a positive impulse at the core of any symptom, any illnesses. But we'll be talking about that in details in the future. I'm rambling a little bit because I'm stressed as well for known reasons, but that will wait. Okay, so which task psychiatry has? Psychiatry has the task to study the rate of mental illnesses and their origins, also their pathogenesis, of course, their treatment and prophylaxis, and as well rehabilitation of the patients. And this is very important because psyche is omnipresent in our life, and so we should put a very big stress on rehabilitation of our patients and not just giving them pills and forcing everything on pills. And I'll be talking about that as well. There is a lot to talk about here. Also, we do psychiatric labor forensic and military examination. So, for example, we have all these psychopaths wanted to go to war, for example, because they have a lot of aggression, they have a lot of impulses, and war is a very active field. You are constantly doing something. So they may be eager to go there, but they're prohibited because they will break laws, most probably. They will torment civil people, most probably. And right now it is also very I would say, important to mention that in any war, there will be this group of people with certain conditions which shouldn't be there, but they are there, and they will break rules, unfortunately. So our task as a psychiatrist is not to let a lot of these people to go to war. Unfortunately, some of them still break these rules and go where they shouldn't go. Also, forensic examinations, for example, if the killer was insane in the moment of doing something, or for example, if they need the psychiatric help right now, or they needn't, or something like this. Also, labor examination, because a lot of our patients, they are more concerned about their future. They ask us whether they are able to keep their works, their jobs, their professions. And there is a certain list, at least in Ukraine, of certain occupations which you cannot allow for yourself if you have a certain medical condition. You are not allowed to work in the emergency, medical emergency if you have any psychiatric illness, and you are not allowed to work in the medical sphere as a doctor if you have any psychiatric condition which leads to the cloudiness of the consciousness, for example, epilepsy. And there is also a lot of other jobs there. Most of them are concerned with the responsibility for other people, for example, driving and wielding of weapons, obviously. So we'll be talking about that as well. And of course, we also try to psychoeducate the population because, well, I don't know about other countries, but in Ukraine, a lot of people still think that psychiatric illnesses are a result of the person being lazy, or for example, not having anything to do, or like to be for being like a result of the person of being a result of a person being sad or weak or weak-willed or something like this. So here is that. And also psychohygiene, and we'll be talking about psychohygiene as well. Okay, so there are different sections of psychiatry. And for example, there is pediatric and juvenile and geriatric psychiatry. It is very important because, well, children are pretty much different from the adults, and old people are very hypersensitive to all the psychotropes. And I need you to understand that our medications we use in psychiatry, they're very potent. They should be titrated, most of them. If you don't want to kill your patient off, you should be very careful with those. Not to mention that a lot of them are prohibited or are listed, and you should use special blanks for them in order for the person to get the receipt and to be able to buy these medicaments. So here is that. There is also narcology, which stands a little bit away from the psychiatry, and personally I chose psychiatry because I love endogenic psychosis more than exogenic disorders caused by ingestion of narcotic substances. There is also forensic psychiatry, which I mentioned before, with the examination. Social psychiatry, when we are talking about big groups, people and how they interact. Nowadays it is also very important because I have seen those people hiding in the shelters from bomb rings, and it is very important to consider how they move as a group, because one person who is panicking will make another person to panic, and another, and you'll have a big array of these people trying to get out of the shelter because they're panicking. So you should always consider how these big groups of people influence one another. Also, we have psychotherapy. Okay, psychotherapy is listed as a branch of psychiatry in many textbooks, but it is actually incorrect. Psychotherapy is a practical section of philosophy, which can be used to treat people. Psychotherapy mostly originates from the psychology, and in Ukraine in particular, unfortunately, psychiatry and psychotherapy are not very friendly to one another. Most psychiatrists would even say that psychotherapy is unimportant, ineffective in our patients, harmful at times. And listening to this, psychiatrists mostly, I have stumbled upon complete ignorance in the field of psychotherapy, because psychotherapy can be very broad. There are different methods which are used for different people at different stages of their illnesses, or for different stages of their life, even if you're talking about a healthy population, like mentally healthy population. And so I wouldn't be so absolute and categorical, in my opinion, if I would say that, like, no, psychotherapy doesn't work. It works. It works if you use it with knowledge. When we will be covering the treatment of mental illnesses in the last lesson, I will be talking about how to use psychotherapy wisely. Though unfortunately I'm not a psychotherapist per se, but I have participated in the group psychotherapy, so I have little experience in this field. Well, when I wanted to be a psychiatrist, I always thought that I would do psychotherapy, but no, psychiatry is mostly about biological therapy. Okay, I'm rambling once again. I'll be talking about everything in the future, in the proper time. Okay, there is also psychoneurology, or also neuropsychiatry. And this is very important because basically those are scientists talking about certain centers in our brain at which the psychic functions are located. And this is important because our medications target these neurological circuits. We are not treating like the illnesses per se, we are treating the certain symptoms. And this is another thing you need to understand. In psychiatry, most of the treatment is symptomatic. You may have different neurological groups, but the same treatment because they have the same symptoms, the same neurological circuit used in the pathology. So here is that. There is also sexual pathology, of course, also a very important branch. Also suicidology, because it is a very big and deep problem when the person decides to take their own life. And it is not just due to the person being weak or something like this. It is a much deeper loss of the contact with the world, loss of something valuable to you. So you shouldn't overlook this. Okay, there is also military psychiatry. Once again, very important nowadays. War is an extreme place for the person. It is extreme stress. It is a direct threat for the life, and many people are not used to this. Many people are not ready. And even as a psychologist works with you, you may not be ready to see and to partake in the actual war action. So that's why military psychiatry exists. There is also ecological psychiatry. This is pretty much new. Mostly the connection of the ecological factors and the mental health of the person. There's also penitentiary psychiatry. So people who get into jails are also a very particular type of people. When we'll be discussing personality disorders, we'll be talking about those. And of course, there is a lot of disorders which may arise in the confinement conditions, when the person is restricted from most of the usual patterns of relieving stress. And this is also very important. People who are quarantined, people who are isolated, people who are hiding in shelters, for example, during the wartime, people in jails, they have restricted access to their usual lifestyle patterns. And this takes a toll on their mental health. Okay, also, there is such thing as transcultural psychiatry. And why this is very important. So when I was sitting at home one day during the summer, I was contacted by a woman from America who has passed one of my online tests. Sometimes I toss online tests online in order for people to fill and for me to collect statistics and analyze the data. Okay, so she filled one of my tests. She wanted to discuss the results. So this woman, she was Native American. She was living in one of the reservations. And soon enough, from talking to her, I understood that she has illness, a serious illness, which is chronic, which is prone to become more acute with the time. So most probably she had either schizophrenia or schizoaffective disorder. I wasn't really sure because, of course, I didn't see her personally. And this is very important for us to observe our patients, not just via their messages, their speech, but also visually. And she started exacerbating right in front of me while texting me. And she started talking about her folklore, about the gods they worship, about the totems and stuff. And I became one of the goddesses in her folklore while she was describing this for me. And it was very hard for me to navigate her delusions and not to become too entitled with, too entwined with, by them, because I didn't know her culture. So it is very important to know the culture, because when the person falls into the state of psychosis, their thinking becomes disorganized, and their thinking becomes very bound to the loose associations, to the symbolic reflections of their mind. And you need to know these symbols if they belong to some certain system, because first of all, the person knows the meaning behind the symbol in their folklore, and they're using this meaning, but also they may distort it by the associations. If you do not know the original meaning, you cannot understand what the association means to the person. But that's like an in-depth course of psychiatry. As far as I have seen in my hospital, most psychiatrists do not like to dwell too much in the thinking of their patients. And this is understandable, because all of us are scared of becoming ill. And I will be discussing this in the future as well, why they're so scared about of this. But I would say that this is actually very important and very useful when you try to understand how your patient thinks, not in order to play along with them, but in order to choose a correct treatment for the person, so that this treatment is as much adjusted for them as possible, because then there is a high chance that they will go along with your recommendations. So here is it. Yeah, and also psychopharmacology. So psychopharmacology is the art of using medicaments in order to treat mental illnesses. That's how I would put it. Okay, so all the mental disorders, and you may have heard about this from me previously, but all the mental illnesses can be divided into groups called, or registers. At the moment I'm recording this, I have heard that these registers have become obsolete in the West mostly, but in Ukraine we still use them. So these three registers differ by etiology of the disorders, their main traits, and the treatment usually used for these disorders. So, for example, we are talking about when we are talking about psychotic state. First of all, there should be at least one of the following signs. There may be change of consciousness, organs of consciousness, delusions, so the disorder of thinking, and or hallucinations. And in this state, in the psychotic state, usually it is not the innate state. The person isn't born in psychosis, that I have explained it before. Yes, it is a certain state the person enters, and usually people are not able to critically assess their condition. When we are talking about critics, most of the psychiatrists mean that whether the person acknowledges that they are ill or not. But let's be frank, nobody wants to acknowledge that they have problems. Even so, the problems with their mental health, which is stigmatized. So most of people will deny that they have a problem. But what I urge you to ask your patients is that, do you think that what is happening with you also happens frequently with other people? Do you think this is something only personal to you, only something which happens only to you, and why? Do you think this is something out of the ordinary or not? So usually people may give different answers on this. And I would say to you that the person with hallucinations who says that, yes, I know that I hear voices and I don't think this is usual for me, I would say this is better than the patient who says, well, everyone hears voices. Everyone has a voice in their head, like telling them to do good or bad things. Like you always have your inner voice, don't you? So the first the first patient has a better prognosis because they are much more critical to what is happening to them. Yeah, and also the third question is whether your experiences, for example, voices, yes, hallucinations, or like different emotional states, do they influence your life directly? So if the person says, okay, I hear voices in my head, but I understand that they do not influence my life, they are not able to influence the reality, this is better than when the person says that I have a voice of the God in my head, and everything that God says should be done and or will be happening in the most in the nearest future. So the second case is much worse in the prognosis. So here is that. I also used to do such trick called scaling. So there is a method in psychology called scaling. When you choose a certain point from which you start a countdown and you choose the final point. So on the starting point, the level of intensity of a certain feeling, state, etc. is minimal. And the closer you go to the final point, for example, to the far end of the wall, the more intense this feeling state becomes. So I was doing this with the critics, and I would say that my starting point was at the door, and my final point was at the chair on the far side of the wall. So halfway to this chair, I have noticed that everything is wobbly. Like the walls are moving, the chair starts changing the form and stuff. I didn't go all the way, but this is the main thing which happens in psychosis. In psychosis, the person is almost experiencing a dream while being awake. So, for example, when you are dreaming, you do not ask yourself, how did you get from London to Washington, for example, in the blink of an eye. You don't ask yourself, you just teleport there. The person with psychosis doesn't have the links between the events in their life, between the states. They do not ask questions why this happens. They just react to things happening to them. And most frequently, these things only happen to the emotional states or to the perception. So not something which is real, but they react as if this is real. Also, in the dream, for example, you do not ask questions why the text on the letter you're holding in your hands is changing constantly. You look away, you look back, and the text is changed, but you don't ask questions. So the person in psychosis is like that as well. They do not ask reasons, they do not ask themselves why the object is wobbly, why it is changing form right in front of my eyes. How is it able to change its form? Such stuff. Okay, what about psychotic state? No, those are the main 2 points. So one of the 3 symptoms: cardinal consciousness, delusions, hallucinations, and a certain loss of critics. Then there are non-psychotic or borderline mental disorders. Most of the neuroses fall into this. Also, constitutional states, for example, like personality disorders fall into this category. So usually people with non-psychotic mental disorders, they have problems with their will and with their emotions, but their critic stays intact. Their critic stays intact, and they do not have any hallucinations, delusions, and coordinates of consciousness. But once again, I emphasize the thing about consciousness and the thing about critics, because it is crucial. The person who is very aestheticized may experience the hallucinations. For example, when I was a student and I was sleeping only for 1 hour a day, yes, I experienced hallucinations, but not because I was mentally ill at the moment, but because I was intoxicated and stressed out, because I needed to go to sleep, because I was dumb. So I had a borderline mental condition at that moment, but not a psychosis, even though I had hallucinations. So that's like one of the main problems and difficulties with our discipline, is to differentiate between all these states and to understand what is happening with our patient. And yeah, another thing which I wanted to tell you is the difference in treatment. So when we are talking about psychosis, we use a very particular group of medicaments called neuroleptics, and we will discuss this group of medicaments later on. When we are talking about non-psychotic mental disorders, mostly we use the medicaments which tackle emotions and volitional sphere, for example, different tranquilizers, soporifics if the person has a distortion of their drives, etc. So here is that. Also, the third organic disorders, the third registry. So people with this disorder usually have a certain impact on their nervous system. So something has happened directly to their brain, directly to their nerves, and this is producing psychic symptoms. So here we want to tackle the organic disorder first and the psychic symptoms second, because we have a direct reason, if of course we can treat it. For example, epilepsy falls into this registry, in fact, organic disorder. Mostly the fact organic disorders manifest themselves through disrupted intellectual functions. So dementia, for example, loss of memory, for example, people with psychoorganic syndrome as a result of the use of substances and stuff. So here is that. Critics may be present or maybe not here. It depends on a certain condition. And I need you to understand that the person with the defect organic disorder may have a comorbid psychotic disorder, for example. So with dementia, man may have a dementia-related psychosis. But this doesn't cancel out the organic disorder, especially if the reason for this disorder is not eliminated. Okay, so also mental diseases can be divided by their etiology. So there may be exogenous, so caused mostly when the most of the reason falls onto the outside factor. So there may be infectious, traumatic, intoxicating. There may be somatogenous and endocrinopathies, so caused by our inner disbalance of the hormones. There may be psychogenic. So psychogenic are mostly borderline states, but sometimes they may be, okay, I'm listening, sometimes they may be psychotic. So psychogenic means that the psychic shock was playing the role, the psychological factor was playing the most vital role in the development of the disorder. Also, there are endogenous. When we're talking about endogenous, and I have mentioned that before, usually we count them for the genes. So the person was born like this, they were born with the predisposition. And once again, it is a certain condition becomes an illness when it disrupts your life. But if you learn to use it constructively, for example, people with the increased mobility of their limbs, they may be ill, or they may be a very, very famous gymnast. So here with endogenous, we are talking like this. So this could have been a skill for the person, but unfortunately, they are not able to master it, and they have fallen victim to this condition. So here is that. And that's why I was telling you that you should have a certain talent to fall ill with a certain illness. So it is in your genes, it is a certain condition. And when we are talking, so why psychiatrists are so scared of becoming like their patients, and why most of them ultimately become. There is a variety of ways which can be used to relieve a certain tension in the person's drives, or to give way to certain genes stored in us. And being ill is only one of these ways. There is a variety of different other ways. For example, you may project certain conditions onto your partner. You may choose a certain way of death. You can have certain hobbies, for example, like people who could have been murderers, for example. They choose to study criminology or something like this. So they do not become murderers, but they study criminology. And for example, you may choose even your occupation in order to relieve your stress connected to the certain condition. So psychiatrists are just like that. They could have been ill, but they have chosen to become doctors. So to get a hold of this condition, to control it. And through this control, the best we are controlling ourselves, the best we are able to help our patients. So when we are trying to run away from understanding their conditions, we are basically running away from our own condition because we are scared to fall ill. Unfortunately, of course, yes, not all people can master these conditions because they are very heavy, and ultimately most of the psychiatrists become just like their patients. But that is something which is a fact, and it is a very interesting thing. It gives us insight into our psyche, and I think it is a great advantage if you are able to do something with yourself in order to help other people with this experience as well. Same thing I can tell you about, for example, surgeons. A lot of surgeons, as far as I have asked them, they become very irritable when people say that, oh, you are killers, you are like cutting people up. What I see here, there is a certain skill of the person, a skill to dissect tissue, and dissect tissue very, very, I would say, intricately, very carefully. Yes, this person could have been a murderer, for example, who would who would take hearts out of the victims, for example, and store them in jars in their home. But they have chosen another way. They have chosen to put the effort in order to get an education, in order to work hard, to master the skill, in order to use it to help other people. They may have this anger inside of them, which could have led them by the path of the murderer, but they have chosen another path. So there is nothing bad about this conclusion that they have a lot of anger or like the inclination to kill, because they're using it socially. They're doing a good thing. And that is another example of the occupational substitution for a certain illness, for example. So here is that. Also, there are psychoses of old age, personal and senile, because when we are becoming old, our body, our brain, unfortunately, cannot excel at its functions on the previous level. So certainly people may fall into the psychosis. So here is that. Also, abnormality in personality development. So oligopsyche and psychopathies. So some people, once again, are born with a certain predisposition, and sometimes this predisposition alone can cause a lot of problems for the person. So, for example, the person may have diminished intellect, or the person may have a certain accentuation of their character being brought up to the max, to the point when they are unable to cope with it and to cope with other people coping with them. So here is that. Okay, so I have talked about this, I've talked about that. So yeah, what else? I have talked about stress. Okay, I won't be talking about the history of psychiatry in details, but I will note certain case stories you might have missed. So, our consciousness of the modern person is different from the consciousness of the person of the old age, of the ancient ages. And when we are talking about that, like people haven't experienced psychosis, no. The things which are considered psychosis right now were considered normal in the ancient times, and vice versa. I have seen lectures on the psychology from the 70s, And the lecturer told us that the person which was described in the book of Ulysses was deemed by the people of that time as schizophrenic. But actually, this type of thinking of the character from this book is a perfect reflection of the type of thinking of modern time programmers. So it is perfectly normal right now, but it was abnormal back then. When we are talking about Middle Ages, for example, it was perfectly normal for people to talk with gods, to talk with voices. Everyone hears voices. Everyone hears the voice of God. Zeus is living on the mountain right beside your home. So that's nothing surprising. Because to the ancient person, there was no internal monologue. They were externalizing their emotions. They were projecting their emotions on the outside world. Therefore, when they were thinking about something, they were hearing their words inside of their heads. They were thinking that these were coming from the outside. Those were the words from the God. So at that time, this type of psychosis was socialized. And these people who were hearing the gods, they were oracles, they were priests, and other occupations like this, and they were not deemed insane. So also another thing like this is about drugs. So a lot of drug addicts like to tell me that, you know, like in ancient times, everybody was smoking weed and eating mushrooms, and everything was fine, and nobody was hurt from it. No, actually, since these substances usually gave you some divine experiences, from this point of view of ancient people, of course, they were accessible by only a chosen few. And for example, we would have a leader of the tribe, and the leader of the tribe has this mushroom, for example, he uses in order to get in contact with the higher deities. And you come to them and you ask them to give you the mushroom. This leader would examine you, and this would be like the primitive form of psychiatric examination, would examine you in order to determine whether you would fall into a psychosis from this experience or whether you would benefit from it. Because nobody wants to have a lot of lunatics running around the tribe. They would compromise the chances for survival. So nobody wants that. It wasn't like that people were like walking around eating mushrooms and consuming drugs. No, it was controlled but in a different form. And the problem of our age is actually that these substances have become widespread among people who wouldn't be deemed worthy by those ancient priests because of this, because they have conditions which would exacerbate under the influence of these substances. So that's another thing you need to understand. Okay, we have talked about this. I won't be talking about history. I don't really like history, and you are listening about the history all the time during the lectures. Okay. Okay, so in the ICD 10, our rubric is F. In ICD 11, I haven't really grasped all the codings in that classification, but apart from the International Classification of Diseases, we also use DSM-5 from America, which sometimes has much more detailed categories. But usually in Ukraine we use like two classifications together. Official one is the ICD. Okay. So about the main principles, there are 10 main principles worked out by the mental health department of the World Health Organization, and those are the principles of the psychiatric aid. So we need to develop the mental health for the people and prevent the mental disorders. So every person has to have access to the measures to eliminate these problems. Also, we need to assess the mental health in compliance with the general principles of health assessment. Also, we shouldn't restrict the person too much. So all the prescriptions all the regimes we provide for our patients should be justified by the condition. Also, if we use restriction, for example, physical restriction, we revise it every 30 minutes. And there is usually a very big commission of doctors who are revising this condition. Also, the patient should be concerned with the interferences unless they are unable to access their state and they are dangerous to themselves or dangerous to the other people. So here is that. And I will be talking about those as well. Yeah. Yeah, also, all our patients have a right to have a lawyer or a social worker helping them. Also, we need to be able to reassess their condition. So it is not like you have this stamp on your forehead that you are ill and you are ill forever. No, it is not like this. Also, people who are assessing the person should be qualified for that. And this is a very big problem when, for example, in Ukraine, we have a lot of psychotherapists, which are actually psychologists, which are in their regard not very competent in their field, even in psychology. And of course, because of those people, we have a lot of problems with our patients, because once again, we need to have a certain time, certain stage, and a certain type of person to use a certain method of treatment. And of course, everything is done according to law. And if you are a bad psychiatrist, you have a lot of problems with the law and with the lawyers in particular. Okay. We have talked about this. Yeah, another important thing is that you should consider at which conditions the patient lives at their home. Because you shouldn't prescribe, for example, the most expensive medication to the patient who isn't able even to buy a single pill. It wouldn't have any use. For example, it is done to try to influence the patient with the drugs to be much calmer, for example, to be less anxious if they have constantly fights at their home. So maybe you should resolve the situation at their home. And why their homes are important? Because they're the psychosocial environment for the patient. And our patients are very tied to the psychosocial environment. Not to mention that everybody in the family, and when I'm talking about psychosocial environment, mostly I'm talking about the closest people, so relatives. Everybody in the family has a certain role, and a role of being ill is also a role with its functions. When the person is ill in the family, it is very good because we can blame everything on this person. For example, nobody wants to talk to us because we have a mentally ill person in our family. We do not have money because we spent everything on your health problems. It is because of you that I had to leave my usual job and to choose a lower occupation because I have to look after you. This is because of you, this is because of you. If you try to treat such person, their relatives most likely will interfere with your progress, even if the patient is compliant to the treatment. Because they understand that once he becomes healthy, they will have to control their lives. They will have to influence what they have become. And they have to rearrange the function he was bearing. And nobody wants to do this. Nobody likes that. Those functions are usually very nasty. That's why this person is ill, because the burden is just too much. So you should take this into account. There was this case in the admission ward. There was this boy who was suffering from voices for a year, and these voices were telling him to kill his parents, and he was like 8 years old, 12 years old, something like this. So he ran away from his house in order to keep his parents safe. And his father was sitting right beside him and hearing all this horrible story from his son. easy. He started shouting at his son for the lies, he told the doctors. So obviously now we see that this parent is interfering with the treatment of their child, both because they cannot bear the guilt for feeling that they may have had a hand in the illness of their child, because children are much more dependent on their parents than adult patients, but also because then they have to change themselves if they want to change the course of the illness of their child. So here is that. Okay, what else? Let's have a break for 15 minutes and then we'll continue. Okay, I hope you will forgive me. The tilted unfortunately, horizon. Unfortunately, you have to continue like this. Okay. So we have talked about this. We talked about that. Yeah. You understand, of course, that we shouldn't use our competences in any medical field in order to harm the patient, especially someone as vulnerable as psychiatric patients. Okay, what else? Yeah. Uh, what is the main difference between the psychiatric hospital and the hospital you have in the somatic region of the medicine? Well, first of all, we have all the doors on locks, and this locks, unfortunately, I wouldn't show it to you right now, maybe next lesson. These locks are unusual in order for the patients not to pick them up easily. Also, we usually do not have the doorknobs because the patients, especially those with suicidal thoughts, may choke themselves on the knobs. For this same reason, for them being harmful for themselves or for other people, there is a variety of objects not allowed in the wards. For example, cords, laces, ropes, different acute objects like knives, scissors, etc. Pens sometimes they are not allowed. Uh, Even though I would say that if the person wants to kill themselves, they will find the way to kill themselves as easy as just starving themselves to death. Even though it is very hard to do in the hospital, but you know what I mean. So here is that. Yeah, also different like headphones, which are on cords, they are also not allowed. Only in the wards where, for example, the people with lighter cases are still living, there they are allowed these objects, but usually it is under the responsibility of the head of the ward. So if something happens, there are questions to the head. What else? In the hospital where I worked, the windows didn't have unbreakable glass. Because if you have unbreakable glass, at first the patient will break the skull on the glass and then the glass. So it is best not to share the expenses on such materials. And it is best to have just grates on the wall, on the windows. Also, in the movies, it is very often portrayed that the hospitals, mental hospitals, have these soft walls where the patients who are very active can find their relaxation. Unfortunately, it is far from truth because it once again it only leads to the further harming of the patient, and if the patient is too active, we just fixate them and the use of course medication first and foremost, which helps to calm the patient. And these walls which are soft, well, it is good that they are soft. It is good that they are soft, but unfortunately the patient may try to eat a part of the wall and choke themselves on these particles. So it is once again not very safe. And since I have already mentioned, our patients are often like children, so they will eat things which are unedible, and they will try to kill themselves by a variety of means, any means possible, basically. Okay, so here is that. I have talked about this. Yeah, about their attitude towards the patients. I have talked about a lot of patients toward themselves. See them inherently as bad people, as dangerous ones, as somebody to be fearful. These patients may not be able to get example if you are already aggressive towards them and they expect aggression. They will find you as and try to understand that the person is no intuitions they have. Sometimes they make actions and back to you. They're not doing that out of their ego. You should, of course, think about your own safety. And that's why we have sanitars, for example. That's why we can have cards. Also, you should run, for example, if you find yourself in a very unpleasant situation, and you should always find help. Personally, I'm not very strong physically. Even if you are strong, you need under the medical conditions, under the influence of the psychiatric illness, the patient will become much more, much stronger than they were before due to hormones, due to the neuromediators. So to wrestle with them is a dash fish. So I wouldn't advise you to try to tackle the patient head on when you're a doctor. There are sanitars for this, and usually we have a variety of them on the scene in order to help. Why I'm talking to you, telling you about aggression. When I was an intern, there was this guy who was older than I, and he was an intern of the second year. And he was showing me around the ward because I was a newbie, and he wanted to tell me like how to live here, how to behave and stuff. I was listening to him, and he mentioned to me that he has been choked 5 times throughout the previous month, and he doesn't understand why. And I was immediately very tense because, like, okay, I am too weak to fight off, so probably I should be very careful with my patients. So we went to the part of the ward where the patients who are psychomotorically agitated are stored, where the patients who are aggressive, so it is the observational ward. There are 2 parts: sanatorial one, when the calm ones live, and the observational one, when we should observe these patients. And so in this observational part, there were also criminals, like people from jails, psychopaths, so very interesting people. And in one of the rooms where the most unkept patients were, and like our patients, due to they may experience problems with the hygiene, for example. So there was one of those was. And when we came to this room, my senior intern told me, you can cover your nose if you want because they stink. And he told this very loudly. Everybody in the room could hear him. And I saw the gazes of those patients looking at him. And I knew that he would be choked once again. And again and again and again. As long as he has this like down-looked attitude towards these patients. Because he was looking at them as if they were with him. And they didn't like it. They were ill, but they understood. They are disrespected. They didn't like it. So that's why I'm telling you that you should remain a doctor in the face of any patient you have. Even if this patient is, for example, a soldier from another war, even if this patient is mentally ill person, even if this patient is the nastiest one you have seen in your whole life, you're a doctor when you're working. So here is that. Okay, also, some patients may be very grateful for your work. They may try to give you presents. I urge you to accept the present because the gesture is always very treasured by these people, especially they very like when they are taken seriously by the doctors, when the doctors listen to them and when the doctors understand them as people. But I urge you not to use the present and not to eat it or drink it, for example. There was a case when one of the previous heads of the ward was rewarded with pancakes from the patient. And the thing was that these pancakes were stuffed with something red, and this red stuff was actually the menstrual blood. So you can guess how very surprised everyone was. So that's why I'm telling you not to eat such stuff. So once again, not because of the EU, but because it means something. So for that patient, she wanted to make the head to fall in love with her potion made out of this menstrual blood. So that was her reason to do so. They may fill the food with the puke, with the feces, with the urine, by anything they want, if they can. So it is good to accept the present, to show that you care for this present and you appreciate the gesture, but not to use it. Okay, what else? Yeah. So one of the main problems when you are working with patients is gaining their trust, especially given that a variety of our patients have paranoia and they are very distrustful to other people, not to mention the doctors. So there is a variety of tricks you can use in order to gain trust quicker from the person you see for the first time, especially when you don't know anything from the person. One of the easiest one is called psychological adjustment and mirroring. So you may breathe in unison with your patient. So for example, when your patient inhales, you inhale. When the patient is exhaling, you exhale. When the patient is talking, you exhale. How this works? This makes it easier for the patient to identify with you on the psychological level, and consequently this raises their trust towards you. So there is this method, especially effective if you are interrogating the patient in pairs. For example, one student will be breathing and another will be interrogating. Also, the mirroring can be in movements. So for example, the patient is sitting at a certain pose. For example, you see the patient sitting like this, for example, and you may mirror their movement, but not to the full extent. So what I mean by this, you mirror, you copy the vector of movement, but not the strength. So for example, the patient is sitting like this, and you may sit like this, for example, or like this. Once again, it helps to identify with you, and helps when the patient, for example, is very distrustful. Also, this should be done for a certain period of time, of course, to be effective, but you'll see that it is a very useful tool when you see the patient for the first time. If the patient doesn't want to talk to you, or for example, they're too preoccupied with their activities, for example, and they are once again not talking to you. If the patient is unconscious and not able to answer your question, if they're in stupor and they cannot move, they don't want to talk to you, there is another trick which may look mystical to you. It is called substitutional perception. So how it relies on the empathy and our natural ability to sense the state of another person through our own emotional state. People who are very good empaths, they may not need this method because they are using it naturally. People who are psychopaths, like me, for example, they may have problems with experiencing other people's emotions, so they may take use of this method. So the method itself, you see your patient, yes, which you want to assess, and you give yourself an information in your brain, in your mind, that I am this patient, and you try to relax as much as possible at that moment. When you're relaxing, you are concentrating much better on your emotional state, and your emotional state will reflect the state of your patient. So when you are relaxed enough and you have given yourself this affirmation, which redirects your attention once again on your feelings and your emotional state, you may sense that something changed in your state. For example, you may feel much more fatigue, or you may feel scared, or you may feel, for example, weight in one side of your body or something like this. This is the reflection of the state of your patient, of course, somehow distorted from your own perception. Unfortunately, without dissociation, it cannot go because it is a subjective method. It gives you a rough idea what is happening with them without words, but a rough idea. And it should be mastered throughout weeks in order to be used effectively. For example, I was trained to use this method for 4 years straight because I'm not a natural empath. But this is a very good method if you are clueless about what other people feel. So here is that. Okay, and so there are different indications for hospitalization in psychiatric clinic. There are absolute ones and relative ones. Absolute include danger to oneself or other people. And or for example, and this danger includes like medical urgency, of course, so danger for the patient themselves. And there are also relative indications for hospitalization, which include the inability for the person to look after themselves, or for example, if there is no such person who can look for the patient. I call it all in one name. So danger to themselves. If the person is not able to go to the shop and to buy themselves food and to eat, it is danger to themselves because they will starve to death. There was this patient with schizophrenia who was admitted to our hospital, and she was found lying on the ground of her, on the floor of her apartment, malnourished because she wasn't eating. She was just lying there. So she was dangerous to herself, but indirectly because she was starved to death. So here is that. There are also contraindications to the mental hospitalization. So if you have a mentally healthy person, you shouldn't hospitalize them in the mental institution. Not to mention that the existence of patients there is confidential. So you shouldn't like make photos of your patients and to share them online or share any their information without their consent. So a mentally healthy person doesn't have any place to do with the mental hospitalization. Also, people who are in the state of intoxication. If you have intoxication and psychosis, yes, then we can hospitalize such person because we treat psychosis in the mental hospital. We have conditions at which the person with psychosis can exist without the danger for themselves or for others. But if you just have, for example, a drunkard, he goes to the toxicology. If you have a person in the drug intoxication without psychosis, they go to the toxicologist, to the narcologist, not to us. Also, people with the antisocial forms of behavior. So psychopaths have a certain personality constitution, which makes it harder for them to coexist with other people, but they are not insane. They can control their behavior if they put their views for it. They may be impulsive, but they can assess the consequences of their actions. They understand what their actions lead to. And that means that they are a problem of police. So unfortunately, unless they have a comorbid psychosis, for example, comorbid condition, mental hospital doesn't work with the psychopaths. Okay, also, persons with neurotic reactions. They usually do not require hospitalization. They are treated in ambulatory conditions and are referred to the dispensaries. That's all. Also, what else? Yeah, persons with total dementia or with severe oligophrenia. Once again, if they do not have a comorbid psychiatric disorder, but they just have this condition, they need to be referred to the certain houses where these people can live and be cared for. The only condition when they cannot be referred to these internates, to these houses, is when they are dangerous. For example, they have very severe behavioral contacts. And then, of course, they stay at the mental hospitals and are treated for their conditions and are given treatment, because in these houses there are conditions for the person to live with the comfort, but there are no medicaments. They are not given meds at these places, unless they are like some vital meds, like for heart, for old people, something like this. So there are no psychiatrists there. There are no sanitars. They will not help you to tame these agitated patients. Excuse that. And also mentally ill with acute somatic pathology. For example, if you have a patient who is an alcoholic and he has delirium, but he also has an internal bleeding. Well, he would die from the bleeding much faster than from the delirium. Not to mention that any other reanimatology department has perfect conditions to treat any type of intoxication, including delirium. So this person would be referred to the surgical department in order to treat the internal bleeding, and only then they are referred to the narcologist, toxicologist, or for the psychiatrist if the delirium persists. So here is that. Okay. Also, psychiatric aid can be divided into outpatient and inpatient, once again, just like any other aid. And when we are talking about outpatients, we are talking about the psychiatric rooms for children in general polyclinics, psychoneurological dispensaries, narcological dispensaries. And when we are talking about inpatient psychiatric aid, we have different mental hospitals, we have psychoneurological departments and dispensaries with large somatic hospitals, narcological hospitals, specialized mental hospitals in the system of Ministry of Internal Affairs, also daytime and nighttime departments in the which help to rehabilitate the patients. Also, psychoneurological sanatoria for adults and children, and we frequently send our patients there if it is possible, and also homes for disabled patients with chronic or mental diseases. There are also social rehabilitative establishments like medical industrial workshops. Unfortunately, in Ukraine, as long as I know, they are all closed because they were more popular in the USSR, and they were actually very, very useful because a lot of our patients lose their previous qualifications, but they need to acquire at least some basic skills in order to make money for themselves. And these workshops were the ways for the people to acquire new skills. Also, different farms at mental hospitals, and we have gardens around our hospital. Also, sanatorium schools, schools and groups for children with disturbances of speech and other disturbances, and also boarding schools for mentally retarded children. Okay. Also, what you need to remember is that our wards, apart from being differentiated into observational part and sanatorial part, they are also divided by gender and by age. So children are kept with children. Usually in children's department, there is no division between male and female parts. But in adult ones, it is crucial because you don't want to have your patients to having fun all around the ward, which is inevitable, unfortunately. Not to mention that sometimes assaults happen even in the same gender ward. So, for example, there was this case when one patient raped another patient in the observational ward, but it was in another city in Kiev. So, yeah, there is a variety of stories, both sad and funny and bizarre. Okay, what else I have forgot to tell you? Yeah, also in psychiatric hospital there is a variety of different specialists which can be called for consultations. So, for example, if your patient has problems with eyes, it's not the task for the psychiatrist to treat the eyes. We call the ophthalmologist who comes for the consultation. And the same thing goes for the psychodiagnostic measures. So you may think that, okay, I'm a psychiatrist and I can assess the IQ level of the patient. But that's not true, unfortunately. Even if you are a master of these psychodiagnostical methods, you can use them, but your conclusion wouldn't be legal, wouldn't be verified as a conclusion. You need to call the clinical psychologist who would come and then conduct the test of your choice. So, for example, you call your colleague, clinical psychologist, and you tell them, okay, this patient most probably has mental retardation. Can you check, please, their IQ sphere? And so the clinical psychologist checks and gives you their conclusion. And this conclusion is official. And that's a pain for me because I love psychodiagnostical methods and I can use a variety of them myself. But once again, I need to comply with the rules. Okay, what else? We have talked about this. Okay, so methods of investigation of our patients. Of course, clinical interview. Clinical interview is the basis for the psychiatric help because our psyche is most evident in the interaction with the patient. So you need to interact with them. Unfortunately, there is a very minimal number of tests which are biological or instrumental, which can show you the different problems with the psyche of the patient. So mostly we judge the psyche by its production. But of course, we also conduct physical examination, because any comorbid pathology, and you have your patient dying from internal bleeding, and nobody wants to have this mess. So of course, you need to check if there are other pathology in your patient. Also, observation. Observation is also crucial, and I suggest you to observe your patient on different conditions: when they are by themselves, when they are with other patients, or like with other people, and when they are talking to you, because those are three different types of behavior, and some of these types of behavior may reveal new details for you, which may be crucial in diagnosing the patient. So here is that. What else? Yes, psychodiagnostic examination. So once again, our colleague, clinical psychologist, helps you here. Also, neurological examinations, different additional investigations. So neurophysiological investigations, and sometimes it is done by the neurologist. For example, in the ward for epileptics, when I was on internship, there was a neurologist who was working alongside with the psychiatrist. And I have made another video where I showed you the basics of neurological examination. You learn the full neurological examination during the course of neurology, so I won't be able to tell these instructions better than them. But I wanted to show you like the bare minimum you need to be able to do in order to see, for example, if the person has a comorbid organic disorder, or maybe if this person doesn't have psychiatric disorder but instead has a neurological condition. Also, of course, instrumental investigations like X-rays, also laboratory tests, all of them. Yeah. So anything you can think of can be used in psychiatry, but the basis is, of course, the clinical interview. Okay, so I'm very scared of the battery of my device running out. I hope it wouldn't do so. We have very little slides left, so bear with me, please. Okay, case report. Most of the times it is no different from any other case report. So we have passport data, of course. We have instrumental like investigation, examination. We have differential diagnosis. We have the final diagnosis. We have administration of the treatment, etc. We have life history, of course, but what I need you to understand is that the difference is in the analysis morbi, and also we have special examinations, neurological examination and psychiatric examination. So I would put the most stress on these parts. So how the analysis morbi? Yeah. Also, we always take the examination and the interview from two sources minimum: from the patient, which is subjective analysis, and from the words of their relatives, friends, somebody who knows them very well, which is objective analysis. Because once again, the patients may lie. The patients may not understand their full condition. The patients may try to simulate things they do not have, for example, and that's why we need to have different sources. For example, if we do not have their relative present, we call their relatives. So we call their mothers, their fathers, and we try to get information we need. So don't be lazy. Please do this, because it would spare you a handful of problems in future. Okay. So analysis morbi. What we are interested in this case? We are interested about previous hospitalizations, if there were any, previous diagnosis, if there were any, the treatment, and did the person actually take the treatment? Because unfortunately, our patients are usually very sneaky, and they drop their medicaments without going full courses. So you need to know about the success of previous medicaments. Not to mention that there is a phenomenon of tolerance and adaptation to the certain medicaments. So once again, this helps you. Also, if you are clueless how to treat your patient, but you know, for example, that a certain medicament has helped in the past for some reason, partially or fully, you may use the same medicament or one which is relative to them. Once again, to make it easier for the patient. Okay, so here is that. What else? Also, we will ask the patient about the current episode. So, how did you get to the hospital? Via emergency car, or like yeah, via ambulance, or by on foot, or via own car, with whom, what has happened, why, and we always ask about consent. Do you consent to be sent to the hospital or not? And under which condition we admit them to the hospital. In Ukraine, there are certain laws which dictate the conditions at which we are able, for example, to hospitalize the person involuntarily. And there are two types of things: involuntarily treatment and involuntarily hospitalization. And there is a difference. The person who is involuntarily hospitalized is hospitalized because, for example, they are not able to care for themselves, but they have refused, but they have absolute and relative indications to be hospitalized. But when we are talking about involuntary treatment, it is used against people who were in court, and it was justified that they have actually committed their crime while being ill. And so instead of being sent to jail, they're being sent to the hospital. Most of the times they don't want to get treatment. That's why it is called involuntary treatment. And involuntary treatment in Ukraine is done for the period of at least 6 months, and then there is a commission of the doctors which decides whether it is best to leave the patient in the hospital. And there is also court, once again, for the patient to justify and to see if the patient should be released or not. Okay, so now about the most important part, the clinical psychiatric examination. I will send you the file with the case history plan, because once again, I hope you find a way to interrogate at least one patient somehow. I'm still thinking about how to do this, but you have a blank for your case history, and you have the plan there, but just overview of what you need to do. I'll tell you it right now. So the neurological examination will be a separate video, but about psychiatric assessment, we start from what we see in the patient. And usually what we see is that is there in contact with outside world or not. So the contact may be full or incomplete or absent, for example, when the person doesn't react to their names, doesn't react to any other stimuli outside. So that's the contact. Then orientation. So does the person understand who they are? This is auto-psychic hallucination. And does the person understand where they are? Our psychic orientation. We'll be talking about those in the next lesson as well. Maybe you can change the pose, or you cannot because there is just too much of the tonus of the muscles and stuff. So psychomotorically. Also, on this stage, usually you can already see if the person is hallucinating, for example, because usually people are actively reacting to what they hallucinate, either via movement or via emotional response, like moving their face and stuff. So yes, also, let's go according to plan. So contact, orientation, movement. Then we look at their perception. So for example, we may ask the person about how they feel the outside world. So what about the colors, what about the sounds, what about the temperature, the sensations inside their body, etc. And in this sphere, usually we find out the different hallucinations the person may have, or like hyperesthesias or esthesias of different analyzators. And I will be talking about these disturbances as well today. Okay. Now, what What else? Not today. Or today? Yes, today. Everything is fine. I'm just checking the plan. Okay. After this, we usually check the intellect and the memory of the person. Usually it is we check the intellect throughout the speech and the memory throughout the questions about their plans for this day, plans for the previous day, about the childhood and about their personality. And sometimes we may ask, for example, if they remember our names, if they have told them our names. Also, we check the thinking of the person, and thinking is checked indirectly throughout the speech, because we look in the ideas, how they form these ideas, how they link ideas together, the rate of the speech. And when we will be having the next lesson, I'll be talking about these disorders of thinking in particular. Okay, then emotional sphere. So once again, you can judge the emotional sphere from the movement of their body, from the movement of their face, so the expression, the emotional expression. Change the tone of the voice. For example, my voice is very lowly, it's very low modulated. I do not use intonation in order to accentuate stuff. I use volume of my voice. Okay, what else? What else? Emotion. Yeah, and of course the person may express that they are sad, for example, or something like this. And you should be very about disruptance in the complete picture. So, for example, if the person claims that they are depressed, they usually have this complaint. Yes, they are talking about it. You may see the sad expression on their face. Their voice will be very quiet. Their movements may be retarded. Their concentration will be very, very bad. They will have bad memory. They will have very slow thinking because they're just depressed. So you have an integral picture. And if you have some elements falling out, you may suspect interference of the signals. And these signals may come intentionally when the person is simulating, for example, or when the person is lying, dissimulate the symptoms. Or they may come unintentionally in case of the fall of the integrity of the nervous system of the psyche, for example, in case of schizophrenia, when there is a disruptance from different functions of the body. So here is that. Then we also judge the affective evolutional sphere. So the drives of the person, how they eat, how they sleep, what about their sexual function, what about their other needs, how they satisfy those needs, do they have any motives to go for the life in the future, for example, do they have any plans? Do not be afraid to ask about suicidal thoughts, because it influences both the treatment and also the severity of the observation of the patient, because once again, people with suicidal thoughts are usually not treated ambulatory as outpatients. They need to be treated as inpatients. So here is that. Oh, you can try to treat them as outpatients, but it is a very great risk. So unless you know absolutely what you are doing, it is best not to risk it. Okay, we have talked about this. Yeah, and also critics. We always write about critics in the end. So if the person is able to fully assess the condition or not. Okay, I have talked about this as well. Okay. So different interesting things about the patients. So I have had this patient in the first psychotic episode ward who was a foreigner, and my colleagues who did not all know English, they have written in the diaries of this patient that they are unable to come into contact because of the language barrier, and they do not tell any details about their state. I came up to this patient, asked them, do you prefer speaking in English or in Russian, for example? And they have told me that in English. And when I was talking to her in English, I found out that she is perfectly in contact with other people. She's actually very talkative about her symptoms, and she gives you the perfect conditions and all the clinical picture about herself willingly. It is just that she doesn't want to speak Russian. That's all. That's all her preference. So when you are seeing your patient for the first time, try to find anchors from which you can find the appropriate method of acquiring information from them. You need to understand what is important for this person, what makes them talk, because unfortunately when they're in this state, you're working on their conditions, not yours. At first you need to gain their trust, and only then you will make the rules for them, and only then you will take the lead. But at first you need to connect with them in order for them to follow you. Okay, so here is that. Also, yes, stigma. A lot of patients are afraid of stigma. Because once again, everybody is scared of losing their mind. And so you need to understand that they are very generous and very grateful to those who listen to them. And this, once again, can help you when you're trying to treat them, when you're trying to find this key to their heart. Also, I have mentioned that the patient may be aggressive towards you, but not because they hate you or something like this, but because they react to some stimuli they have in their psyche, and they just attribute this stimuli to you. There was this case when the man with schizophrenia has attacked one of the food companies, I remember, if I remember correctly, because he saw a commercial for this food company on the TV. In this commercial, there was this evil gnome called Noid, and the slogan for this company was "Avoid the Noid." And the thing was that this patient, he was called Noid, that was his name. And when he saw this commercial, he thought that this was a conspiracy against him in order for other people to despise him and to avoid him. And so that's why he became angry and he attacked the workers from this food company. So once again, it's just the logic how it works. It is very hard unless you see the actual mentally ill people, unless you talk to them thoroughly and for a long time, to understand the difference between the usual, for example, I would say, between the usual sadness and the grief of depression, for example, between the usual delusional idea of the person, which is not pathological, but just like the person doesn't understand what they're talking about, and the delusion when the person is defying all the laws of logic or common sense, and is insistent and is able to go to the end with the idea, even if it compromises their own health in their life. Yeah, another thing, another sign of an illness, I forgot to mention before. Another sign of an illness is that the person is the person need to knock on the wood 31 times, so they cannot sleep because they're constantly looking out the window trying to check if anybody is spying on them. So when the person starts neglecting their basic needs, you understand that something wrong. And sometimes, once again, I have mentioned it, some people may say, oh, well, I have missed a meal, nothing happens. Sometimes it may happen, like, who cares? Okay, I wasn't sleeping today. Okay, I wasn't sleeping today as well, but if this happens, I was just too stressed out. No, our basic biological needs are primary for us, and they're very important. So if you notice this, for example, even if the person stops caring, for instance, even if the person, like, visually, you see that their head is not clean, if they haven't changed their clothes, there is another comment from them, something is wrong. They may not exhibit cloudiness of consciousness or hallucinations or delusional ideas just yet, but you already see the signs that something is wrong. Okay, we have talked about this. Clinical material, I have talked about this. Okay, laboratory examination. So apart from X-rays, we can also have electrocardiography, of course, electroencephalography, especially needed when we have conditions which are connected to the abnormal electrical impulses like seizures. Also real encephalography, experimental pathological examinations and stuff. We also need to assess hormones frequently of our patients, for example, because hyperthyroid coma may look like a depression at first. But the problem is that our psychotropic medications, they only worsen the hyperthyroid state. And so you may get the patient who was just retarded in their movements, for example, in their reactions, you may get them into coma via your medication if you do not try to check the level of hormones. In this case, it's usually if you see that the person has a temperature lower than their basal level, this is usually the sign of hyperthyroid condition. So be very careful and do not dismiss somatic measurements, which is frequently done in the hospitals. Okay, we could talk about this. Yeah, also magnetic resonance imaging is also very important. Once again, positron emission tomography, so all the types of tomographies are important here. What else? There is a big table in the presentation you got with the psychodiagnostical examination methods, and I urge you to learn at least a handful of ones for each field of psychic pathology, because sometimes you may not have a colleague around you. Sometimes these tests are the only things which can help you to differentiate different conditions. For example, there was this patient in my ward who was being discharged from it, and he was schizophrenic. He was admitted from the court because he killed his neighbor in the height of his condition. And at the moment when I was talking to him, he had no delusions, no hallucinations. His intellect was very high. And well, obviously, if you didn't know his case history, you wouldn't even suspect that he is a schizophrenic. But there were two things which were off. First thing is that he hardly moves his face when he was talking, and he never reacted emotionally to other people. But he smiled onto his own jokes and onto his own experiences. But if I would tell him, for example, that my dog died today, he wouldn't show any concern for that at all. So his emotional expression was diminished, not blunt, not empty, but diminished. And also I gave him a test of proverbs. So sometimes we may ask the patients to explain proverbs and metaphors, and this checks the ability of their psyche to make much more abstract connections between ideas and to read between lines, to see irony, to differentiate between emotional response and context and stuff. And so at first he failed at it. Then he thought a little bit and he gave me a correct answer. But that answer was processed. He already thought about it. The first one, initial one, was the one showing that he had a disorder in thinking. And I knew that schizophrenia, and you need to know this as well, schizophrenia is a progressive disorder which doesn't go away completely at all. And out of all the symptoms in schizophrenia, the disorder of thinking is one of the most uncontrolled ones, because usually we do not control how we think. And that's why this test showed me that this guy actually had an endogenic disorder. But if I didn't use it, I wouldn't understand he was in the hospital. So here is that. Okay, all these different types of I won't be stopping on them. No, it is not signed here. You will see a wall of symbols like Cyrillic letters, and this wall is called Anfimov's test. The instruction for this test is that cross all A's, for example. This test is used to check the attention of the person. Okay, and now the last 15 slides. Finally, last 15 slides. The disorders of sensation, perception, representation, and imagination. So all its disorders. What I need you to understand is the difference between these things. Just a reminder, because I hope that you have learned medical psychology well. So sensation is the basic function. So for example, this pen is pink. I sense that this color is pink. It is an elementary sensation. But when I tell you that this object is firm to the touch, is pink to the color, is also cold to the touch, and is elongated, and I perceive a pen, so I combine all these sensations into one image. This is the perception of a pen. If I close my eyes and I try to remember how this pen looks like, I will see a representation of this pen in my mind. And the representation can be imaginal when I see the image, or it can be, for example, an idea, so a concept of a pen. If I tell you a dog, everybody thinks about a certain dog, but we all understand what this dog, what is a dog. So that is a representation. And there is also imagination. So for example, I can combine the image, the representation of this pen with the representation of the hedgehog, and get a pen with needles on its back. So that is imagination. I can combine previous experiences into something new, to produce something new. And this is important because certain hallucinations are more like sensations, and certain hallucinations are more like perceptions, and some of them are more like representations. We should know the differences of those. Okay, now about disorders of sensations. What can happen? First of all, you need to understand that in all conditions, in all symptoms, we can have too much of a certain function, too little of a certain function, no function at all, or a distortion of it. So when we are talking about sensation, we can remember that there is hyperesthesia, so an elevated sensation of something. For example, in people with neurasthenia who become irritated by any sound or any light. Also, the person in the psychotraumatic situation may be hyperesthetic to stimuli. They may remember things much brighter than they have been in the reality. Also, we can have hyperesthesia. So the person, for example, who is depressed may be very hard to get into contact with, because they literally do not hear you too well. They are hypostatic to the sensations from the outside world. For example, I have seen this patient who was 16 years old, and he had tried to take his own life for 7 times. Last time he was admitted to the hospital with a laceration across his neck. And he had a lot of different scars, very, very deep scars. So I asked him, how do you even manage to do those? Because if I try to imagine myself doing this, I become scared and I feel this pain. And he told me that, my emotional pain was much, much stronger than the physical one, so I didn't even feel anything. So this is hyperesthesia. Anesthesia can happen as well. So for example, people with schizophrenia during psychosis can look at the sun and do not feel burned at all. But outside of the psychosis, they will get burns from the sun. So here is that. Some of these impulse objectively and functionally our analyzers are fine, but the person feels that they don't feel anything, for example. Okay, we have talked about this. Sensations. So for example, there may be synestropy. Synestropy is a certain sensation inside of the person, which is very hard to describe in definite words, but it is always very unpleasant, very difficult to bear, very suffering-inducing for the patient. And usually when the person is describing synestropy, they are saying that, for example, my head, of my heart, so synestropy. A very popular, I would say, very common synestropy is, for example, vital grief, like this stone on my chest. But it is usually it is said just like the feel of the weight on your chest. So here is that. And synestopathies become much worse when the person is concentrating on the sensations. So the first thing is that the person is constantly stuck on what is happening to them, and the second thing is that they may not understand how to differentiate it, because usually this happens when the person isn't able to acknowledge certain emotions, which become somatized. And since these emotions are just too potent for the person to acknowledge them, the person just feels something strange and unpleasant, but they are not able to make out what this actually means, what is the state of it. Okay, there is also such thing as synesthesia. So synesthesia is when the signals from one analyzer radiate to another analyzer. For example, the person hears the music but can also see colors which accompany this music. I have gustatory synesthesia. For example, when I look at objects, I can feel the texture on my tongue and sometimes even taste, but mostly the texture. Not a very pleasant thing, but very interesting regardless. There is also paresthesia. So paresthesia is an unpleasant sensation. For example, you may have felt it when you were sitting in a very unpleasant pose for a very long time because of the deprivation of blood in your limbs. Okay. There are also disorders are usually induced by the intoxication, very popular and very common, among people with drug addictions. And for example, there may be metamorphopsia. So what is metamorphopsia? Metamorphopsia is when the objects change their form in front of you. So as I have discussed with the chair, it was wobbling. So that is metamorphopsia. The objects may become elongated. There is also macropsia, when the object becomes very big, and micropsia, when the object becomes very small. And this is the basis of the syndrome of Alice in Wonderland, for example, micropsia. Also, there may be a certain tint to everything you see. For example, xanthopsia, everything appears yellow to you. Also a result of intoxication. Also, what else? We could talk about that. Yeah, there is also the disorder of the body skin. For example, the head may seem enormous to the person. They may feel that their limbs are much longer than they used to be, and this is the basis for the dysmorphophobia. Those people who want to change their appearance, thinking that they have this obvious form, which is actually fully imaginary and non-existent. Okay, now illusions of perception. So now we are talking about perceptions. We were talking about sensations, and now about perceptions. So what about perceptions? There are two big groups which we need to discuss here: illusions and hallucinations. Illusions are much more like perceptions. They are false perceptions or misinterpretations of the real stimuli. So in illusions, the stimuli for this perception exists in the real life, but the illusion substitutes this stimuli. So what I mean by this? For physical illusion, we can see in the glass how the spoon bends in the water. The spoon doesn't break, actually. We know that it is intact, but it appears as if it is bent. So the image of the bent spoon replaces the real spoon. There is also affectogenic illusion. For example, the person who is scared of maniacs at night, while walking on the empty street at night, may see this maniac somewhere in the bushes, may hear the rustling of the leaves and understand that, for example, it is the maniac who is walking behind them. So that is affectogenic illusion. There is also pareidolia illusion. So when complex forms arise from the elements which are not connected. So for example, you can see the wall behind me. Because I was sleep deprived when I was a student, I I can see faces in the walls sometimes, or in the carpets, and it amuses me. So this is a pareidotic illusion, and what is important, I'm perfectly critical to this. So people with illusions, you can explain to them that what they're seeing, it is not real, and the person will believe you. So usually the person experiencing illusion, no matter how scary it is, tries to test the reality. And this is also very important. The person questions themselves. Yes, what am I seeing? Maybe it is not a monster under my bed. Maybe it is a sock I forgot of 30 years before, 30 years ago, for example. So critics is present here. Okay, and now, okay, there are also images of different illusions here in your presentation. And now about hallucinations. Hallucinations are different. Hallucinations arise from no real stimuli, but they can be triggered by the stimuli from the outside, but they never substituted. They always come along with the stimuli. So it is something foreign to life. And hallucinations usually can be divided into two groups: true hallucinations and false hallucinations, or pseudo hallucinations. True hallucinations are much more like perceptions. So true hallucinations are extra protected. So for example, I see a big dog there, for example, a visual hallucination, and when I try to move my head, this dog will remain there. It wouldn't follow my gaze. So it feels that maybe it is real, because like it obeys this law. So yes, I'm turning away and I do not see the dog. So they obey physical laws. True hallucinations do not pass through walls. If you see, for example, a big wolf sitting on a chair, which is too big for this chair, and the chair breaks, like under the weight of this wolf, it is most likely what happens. But once again, the wolf doesn't pass through the chair. Also, they look real. They are not transparent usually, these hallucinations, though it is said that you may see a certain like film around the hallucination, but it depends on the condition, it depends on the type of hallucination. Yeah, and I forgot to mention that you can get hallucinations in any type of your analyzers. So visual, olfactory, gustatory, and then we are talking about tastes and smells. They're usually very unpleasant because they're dictated by our emotions. And once again, in psychosis, usually we suppress very bad emotions. So the smell of rotting, the smell of feces, the smell of ground from the graveyards, such stuff. Also auditory hallucinations as well. And there are also visceral hallucinations, so hallucinations inside of our body. So what is the difference from synestopathies? I have talked about it. Synestopathy is a sensation. It's an unpleasant sensation which cannot be put into words directly. It doesn't have a direct description. Whereas visceral hallucination has a complete imagery, vivid explanation. For example, I feel burning in my intestines. That is a synestopathy. But if I say that I feel that there is a hedgehog inside my intestines, it is a visceral hallucination. It is a complete image. Or for example, there is a worm in my brain. I see it. It is a visceral hallucination. Or I feel it, for example. Rather, I feel it. Okay. So that's it. That's visceral hallucinations. Yeah, true hallucinations, they obey physical laws. Yeah, also, true hallucinations usually do not get into the interaction with the person. So what I mean by this, for example, the alcoholic who is having alcoholic hallucinations and is hearing people commenting on his habits, he may try to get into dialogue with these voices, but it wouldn't help because they won't reply to him back. They will just go on and on and on the same idea. This is the true hallucination. There was this yeah, and about pseudo hallucinations. What about them? Pseudo hallucinations do not obey the laws of physics. People pass through walls, animals go through floors, for example. You may not feel the object you are trying to reach because it doesn't exist. Also, also false hallucinations, sorry, they follow the gaze. So for example, it is as if it is a sticker stamped onto the reality. So you move and it moves with you because it is interprojected. Also, pseudo hallucinations often happen in the inner eye of the person, or for example, out of the reach of the physical view. So for example, I can see my neighbor trying to cook his meal in his kitchen right now behind my back, but I'm not turning back, so physically I cannot see it, but I see it via my inner eye. Also, false hallucinations deal interact with the person, and sometimes people can even influence the contents and the rate of these hallucinations, but that depends. For example, if the person has auditory hallucinations inside their head, they may get into the polemics with these voices. So here is that. Why I'm talking about this. The difference between true hallucinations and false hallucinations is very important because it depends on the etiology of the disorder, and sometimes may help you in differentiating the real people who are ill and people who are simulating. Jeffrey Dahmer, or not Dahmer, who was that? Ted Bundy, yeah. There was this killer, Ted Bundy, and he tried to justify on the court that he killed people because there was this dog who told him to do this. So he was trying to make himself look like schizophrenic and to be put into the involuntary treatment instead of jail. But he failed because that is a true hallucination. A real dog who is talking to him. Well, he was given much more information about it, but I'm telling you that he described the true hallucination. While in schizophrenia, you have mostly false hallucinations. So that's why he was busted into jail. Okay, so here is that. What else? Voices can be of different manner. Actually, they can be commenting, they can be imperative, they can be menacing, or like inquiring, caring. Depends on the personality of the person and on the source of the emotions and the actual mood. Most of the times, they actually do not say full complete sentences. The person just gets the feeling that they understand what they're talking about. So an example, there was this one of my friends. Once he was under the influence because he was drugged on his voice work. He heard his colleagues discussing his addiction. And at first he became very scared, but then he remembered that he was also a psychiatrist, and he started listening in to this situation. And he understood that actually he doesn't hear words, he doesn't hear sentences, he just hears mumbling, but he feels and knows that this is connected to his addiction. So his fear of being exposed actually influenced his perception of these voices. So once again, our patients are mostly in the under the influence of the emotional states, of the perceptions, rather than logical reason. Okay, so here is that. There are special hallucinations, for example, extra-camping hallucinations, those which are happening out of the reach of our visual field. Also, Charles Bonnet hallucinations or Charles Bonnet syndrome. There was this case when the grandma was admitted to the hospital because she saw a very big dog walking around her apartment. Everything would be fine, but she was blind. She couldn't see anything, but she saw the dog. This is called Charles Bonnet syndrome. Hallucination in the depraved analysator. Deaf people hear voices. Blind people see things. That's why your old grandma is sometimes telling that you're telling them things you have never told, because they are just deaf and they make up this stuff. Okay. We have talked about this. We have talked about that for advices. For another time. What else? Yeah, I have talked about. Yeah, also hallucinations can be simple or complex. Complex hallucinations usually have certain flavor to them, and they have sometimes even signals from different investigators. When we are talking about simple hallucinations, it is just sparks of light, for example, photopsias, or just sudden noise without any contents, not voices, like just noise, which is called aquasms. Okay, we have talked about this. Yeah, I have talked about this. Yeah, also another type of hallucinations. Once again, because I was sleep deprived and because of certain other conditions in my life, maybe I will talk about those, maybe I won't. I have experienced hallucinations before going to sleep and after I have woken up, in the process of waking up. These types of hallucinations are called hypnagogic and hypnopompic. Hypnagogic, when you go to sleep, hypnagogic, you go to sleep, and hypnopompic, when you are waking up. For me, it was not a serious problem because I remained fully critical, and usually these hallucinations were auditory, so I heard phrases and like different dialogues from people I don't know, and I perceive them as entertainment for me, as a radio, but it is not a problem. But it is a sign that I'm most of the times I'm very weakened and stressed out. So here is that. What else? Yeah, also functional hallucinations. Functional hallucinations is when the person is perceiving, like for example, how to explain? Yeah, when the hallucinatory stimulus is perceived side by side with the real one. So, for example, the person hears the rustling of the wind, and in this rustling, they hear voices. There are also functional illusions, but in functional illusions, for example, the person hears voices instead of the rustling of the wind. So, remember, illusion substitutes real stimuli. Hallucination goes hand in hand, goes together with the real stimuli. Okay, there are also reflex hallucinations. So, what are those? For example, the person sees that there is a key turning in the keyhole, and they feel that this key is turning in their heart, but it is actually not not like the reflex, but how to explain? When I say reflex, you may think about the refractory like link chain and such stuff, but here reflex means that the person is reflecting the outside world. So for example, the person in this example is identifying with the lock, and that's why they feel that the key is turning inside of them. Another example would be the person identifying with the tree and then being aggressive towards the woodsman, because the woodsman is cutting them when the woodsman is cutting the tree. So the person is identifying with the tree and also projecting onto it their own sensations. When we will be talking about schizophrenia, I will be talking about this because these patients usually have a very big problem with their identity and with these basic ego defenses, which take part in this projecting and identifying with other people and with this general border between oneself and the outside world. Okay. Also, yeah, there are negative hallucinations, and I have a very funny case for this. So, negative hallucination is when a real object disappears, and these hallucinations can be also suggested. So, you can induce hallucinations in the person who is highly suggestive in state of trance, for example, or in certain states. And for example, there was this case when teacher of my psychotherapist was showing the hypnotic phenomena, and he was showing negative hallucination. So they were sitting in a room with a lot of boys and girls. And this girl who was being hypnotized, she was suggested that all the other girls in the room disappeared. So when she opened her eyes and she was looking around, she stated that there are no girls in the room. And the hypnotizer, he suggested one of the other girls like to check like this if the tested one sees her hand. But the girl who was given this instruction didn't understand the instruction, so she came to the girl and she smacked her face like this. And the girl who was hypnotized, she was terrified because out of the blue somebody hit her, but she didn't see anything. So she freaked out and she started shouting. Then she relaxed a bit. The teacher once again asked the another girl to check if she sees. And that girl once again didn't understand what she needs to do. And she smacked her once again. The girl freaked out once again. It is funny to talk about, but it was very scary for the girl, unfortunately, at the moment. So that is the negative hallucination. Also, phantom phenomenon in the severed limbs is also a hallucination, but also it is a disorder of the body scheme, because for our mind there is a copy, a presentation of our body, and if one of the limbs is missing, our brain doesn't understand what's happening. The limb should be there. Why is it missing? So like this. Okay, about children and juveniles, usually they have visual hallucinations, and their hallucinations are usually very simple. So photopsias and acrosms. It's very rare for children to have full-fledged voices in their head, but when they have, it is usually a very severe condition. And you should observe their parents very closely in this case, because they may have some influence on this case. Okay, I'm dying from tiredness right now. I thought that I would be making 4 videos for the students in one day, but I guess I need to spread it out because it just takes too much time and too much of my energy, especially till the end of the day, because it is already night here and there is a curfew, so I need to close the window. I need to shut off the lights. Okay, I'll send all the materials via mail to my groups. So good night, and we'll see you soon. So I wouldn't marathon with other topics for today.